I'm delighted that Dr. Morten Jensen has accepted our invitation to give a seminar. He is an associate professor in medical informatics in the Department of Health Sciences and Technology at Aalborg University, and senior researcher in Steno Diabetes Center, North Denmark. He's been working in telemedicine, in the machine learning area, and with the real world evidence within chronic diseases. And he also, as he said himself, has been in the dark side. And he worked in the private industry as a statistical programming specialist at Novo Nordisk and responsible for work of 20 people and so on. So he's interested in research in digital health and diabetes. So without further ado, today, Morten is going to tell us about explainable artificial intelligence in diabetes, which I really like to hear very much about it. Thank you very much, Morten, and we look forward to listening to you now. Floor is yours, as they say.
Thank you. And thank you for inviting me. I will just share my screen. And hopefully you can see something now.
Yes, we can see it. Yeah.
Yes, great.
Yeah, that's right.
Oh, what is that? Go away. Okay, perfect. Yes. So I called this little talk Explainable Artificial Intelligence in Diabetes. As you may know, there are a lot of definitions of artificial intelligence and explainability. I will not touch much upon that, but just to say then my interpretation of artificial intelligence in this talk is essentially machine learning. So I wanted to start out by saying who I am, but you have almost done that, Abdul, so that's fine. Then I would go to what is one of our problems, you can say. We are a PBL university, so we work problem-based with problem-based learning. So it's very important for us to really dig into the problem and analyze the problem before we go in solution mode. Then I would like to talk about some of the data sources that we typically work with. And then you can say I will give you a short machine learning recipe, or at least my take on some of the stuff in that area. But as you said, then I'm a senior researcher at the Steno Diabetes Center North Denmark, 80% of the time, and 20% at the Department of Health Science and Technology at Aalborg University. And it's supposed to be the same tasks that I do both places, fortunately. So it's research within digital health and diabetes. I have a background in biomedical engineering and informatics, and I have worked with diabetes for more than 10 years. It was actually a coincidence. I wanted to work with COPD, chronic obstructive pulmonary disease, but then Ole Heilesen, as you know, Abdul, he thought that it would be wiser to work with diabetes because it was more a public known or a prioritized disease, you can say, and that was maybe true. I did a PhD in diabetes technology, but I always had the wish to try something different than university. So I worked for 5 years at Novo Nordisk, pharmaceutical industry. So really the dark side, but not that dark, at least not in Denmark. In Denmark, a company like Novo Nordisk has a good reputation as the good kid in class, you can say. But quickly, or after 5 years, I found that I really missed academia and all the possibilities there. So I went back to Steno and Aalborg University. So one of our problems is hypoglycemia in diabetes. So I don't know how much you know about diabetes, but people have the problem that their blood glucose levels are too high. And researchers in the 90s showed that intensive insulin treatment is cornerstone for avoiding late diabetic complications such as retinopathy, neuropathy, nephropathy, and macrovascular complications. And insulin is the treatment for many patients at some stage in the disease. But then this intensive insulin treatment increases the risk of having a true low blood glucose, so increases the risk of hypoglycemia. And hypoglycemia reduces quality of life and probably also treatment adherence, because it's a not nice condition. You have probably had the same symptoms when you haven't had food for a long time. Yeah, headache, dizzy, irritable, but your blood glucose has probably not been near the hypoglycemia range. And people can also faint, and it has been associated with death. So it's a feared event in diabetes, and it is anticipated that it leads to suboptimal treatment adherence, that people then in some situations choose not to take the right amount of insulin to avoid these hypoglycemic episodes. And then that will lead to that the blood glucose levels in general are too high, which again leads to increased risk of late diabetic complications. So what can we do with that? About that? I'm an engineer, so I need some data. So that's the first step, you can say, to look for some data. And we have access to quite a few sources. For example, in Denmark, we have our registries. We have the Danish National Patient Registry. It's a population-based administrative registry with data collection from all Danish hospitals since 1977. So a lot of data from plus 9 million citizens. And as you may know, Denmark is a small country with only 6 million citizens. So also historic data, more than 20 million inpatient, outpatient, and emergency department contacts. So together with the Danish Civil Registration System and the Danish National Prescription Registry, it is actually possible to extract data from all citizens in Denmark diagnosed with diabetes. So that's a major advantage. So what we could do is to investigate hypoglycemia, first of all, from an epidemiological point of view. For example, a study I did a couple of years ago, where we investigated the impact of severe hypoglycemia on mortality for people with diabetes in a 20-year follow-up in Denmark. So we investigated all citizens, 636,000 people with diabetes, divided them in type 1 and type 2, based on ICD-10 and 8 disease codes and prescription data. And they set up a case control study where people suffering from hypoglycemia were in one group, the cases, and people who didn't were in another group as controls. And we could see that the people here are the Kaplan-Meier survival curves. You could see that the people suffering from these severe hypoglycemic episodes leading to hospitalization had an increased risk of death, both for type 2 diabetes here and type 1 diabetes. And also the Cox regression hazard rate radios indicated that. So here adjusted almost a twofold increased risk of death for people suffering from hypoglycemia. So it is understandable that it is a feared event, and it might lead to non-adherence to treatment. But we will of course not stop there. As an engineer, a biomedical engineer, I love working with biological signals, and these signals from devices are typically only, you can say, available in clinical trials. And another source of nice data is actually the pharmaceutical industry. You can see here that Novo Nordisk writes, in order to facilitate the use of data from our clinical research in further scientific investigation, Novo Nordisk has established blah, 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 a portal for getting clinical data. And that's essentially because the competitors do the same. So Novo Nordisk should also share their data. So they actually share data from all the clinical trials if the drug under investigation has been approved by the FDA and EMA, the European Medicines Agency. So that's actually quite extensive, and a lot of people are not aware of that there are many trials where all researchers can apply for access to these data, and they are of course of very high quality. So I applied for a study, the ONSET-5 study, which was a study investigating efficacy and safety of continuous insulin infusion with a drug called faster-acting insulin aspart compared to Novo Rapid. And the important thing in this study was that it was more than 500 people with type 1 diabetes, and they used so-called continuous glucose monitoring, insulin pump data, and meals or registered meals. And these continuous glucose monitoring are from devices that measures the glucose level in the interstitial fluid. So more than 1 million hours of that. And as you can maybe understand, that is really nice for a person like me. Yes, that was just to explain that they have a sensor on their skin measuring the glucose level in the interstitial fluid. The glucose has to diffuse from the blood vessel, so there is a small delay, and it's not that precise as the blood glucose, but still it correlates very fine. So another idea could really be to see, can we predict hypoglycemic episodes before they occur? Then we can warn the patients, and they can eat a quick meal, drink some orange juice or something like that to raise the blood glucose level. So to the machine learning recipe, first of all, I said problems should be in focus. So we need to think, is machine learning the right method? If we were to consider causality, well, then it should probably be a randomized controlled study we will have to make. or maybe some advanced epidemiology. Then we should also consider, do we have the appropriate data source? The optimal case is that we have one data source, for example, one trial for development of the algorithm, training of the algorithm, and one trial for test of the algorithm. Do we have enough episodes, events, or variability in the data for splitting it up correctly? This is probably something you have seen before. If you have heard about machine learning, we split it up in training data, validation data, and test data. And how should we split those? This input data, and is the input data generalizable to our target population? That is, of course, also very important. Then we should consider, what is the endpoint? Is it dichotomous, ratio, ordinal? That of course is also related to choice of model. Should we convert the endpoint for simplification and for clinical value? For example, this could be a data from CGM, so interstitial glucose levels of a patient for a day. So should we try to predict a point value out in time? So should it be a regression model, or should we convert it to that we want to find events, for example, where the signal was below? Yeah, sorry, this is in Danish, but maybe we would want to focus on periods where the signal was below 3.00 millimoles per liter. So these considerations should be done in advance for setting up the model. So it could be that our hypothesis was that it is possible to predict hypoglycemic episodes during night. We can predict that before the patients go to bed. That is also a case for the patients, that they are sometimes afraid when they go to bed. For example, if the every day has been a little different than the day before, then they could consider if they have taken too much insulin. So a prediction of nocturnal hypoglycemic episodes at bedtime would be quite valuable for the patients. And here, machine learning would definitely come into play. It could also be more like compartment modeling, physiological modeling. That could be interesting. But machine learning could be a tool in this prediction case. And as I said, I would define machine learning as artificial intelligence. And then we talk about the XAI, so explainable AI. And what is that then? Well, we will ask Wikipedia, why not? And here it's written that explainable AI or interpretable AI is AI in which the results of the solution can be understood by humans. I would fold that a bit out and focus on the word transparency, that there needs to be a high degree of transparency. So how did the model come up with the detection prediction, and what characteristics with respect to the input were used, and how were these features or characteristics weighed against each other? And actually, I don't know if you're aware of that, but October 2021, FDA, Health Canada, and United Kingdom's Medicines and Healthcare Products Regulatory Agency came up with a new GXP, the Good Machine Learning Practice, with 10 principles where they say to promote safe, effective, and high quality AI / machine learning. And I think the ninth principle about providing users clear and essential information is related to this about transparency, although it is not clearly written in that way in the text. But this is something you can look into. It's, if you have worked with machine learning, it might be already known information, but otherwise it gives some of the brief overview of some important considerations. So if we then wanted to predict whether a night is whether a hypoglycemic episode is occurring in a night or not, then we need to figure out what should we put into the model. If it was not explainable, then you could use something like neural networks, even deep neural networks, and just put in the complete signal in the model and try to train the model to be able to characterize these nights with and without hypoglycemia. But we will not go for that. So in our case, we believe that this about feature extraction is the most important step. Features, they can be established based on already known risk factors. That could be, for example, from epidemiology. And this is probably, this is my self-citation. My own article about the epidemiology of hypoglycemic episodes leading to hospitalization in Denmark. So here it says something about that different types of insulin, the type of insulin is a predictive factor of hypoglycemia. So insulin type could be a feature in the model. But we should try to think beyond established risk factors when we then use machine learning, because we have computational power today to loop through a lot of features and try to investigate which of these features are actually discriminative. So and you should not be limited by, or we should not be limited by our physiological knowledge and know-how. You can say we should embrace data with an open mind, but we also need to sometimes pre-process and use our domain knowledge to feed the models with some pre-processed data and not only the raw data. And I will just explain what I mean with that. Here is another graph where I'm showing interstitial glucose. So it's a day plus a night, and you can see here the night, the interstitial glucose is not under this limit with the black line here, and that's a limit of 3.0. So if it was below, then we would say that there was a hypoglycemic episode. And if we look in the next graph, then this patient this night had a hypoglycemic episode here early morning. So these are the two cases, and we have some bolus insulin during the day, so meal insulin, and then we have a basal insulin here injection, and probably also some meal times marked in orange. So what characterizes this profile where there was no hypoglycemic episodes compared to the other profile? That's really what we should try to, this is the pre-processing we should try to do if it is within the explainable field, you can say. For example, we could anticipate that the blood glucose will drop fast before bedtime. So we could take the slope of the linear regression of a window just before going to bed and calculate this feature. It could also be that we should take a minimum value of the interstitial glucose the night before or the evening before, and the minimum value, the minimum value of the complete profile, and all kinds of other measures. For example, variation. It could just be the peak and the lowest value, the difference between those, or it could be standard deviation, coefficient of variation of the signal. All kinds of features can be extracted. But a little pre-processing of this signal, which is prone to noise, is a way forward. We believe that, at least. Then, when these features have been extracted from the input data and the classes has been established, so hypoglycemia versus no hypoglycemia, a dichotomous output, then we should split data. And as you probably already know, we can have a split in training. So we have training and validation, where we can have some iterations. The test set will be put completely away, and we will not test on that until we have a final model. So that's quite important. That's like pre-specifying our statistical analysis in a statistical analysis plan and publishing it or putting a note on clinicaltrials.gov, for example. That's the same. We need to put our test data set away and never look at it before the last test. And the split can be done in several ways. There is an assumption that training and test should not be correlated. So we can split on patient level, for example. But there will of course be some correlation if we use the same data from the same trial, because you can say the model will be overfitted to the trial design if it is if the patient were treated in a special way or something like that, that is not generalizable to our target population, then we will of course have a problem. It could also be that we would like to have our model, it should work, but it should not work on new patients right from the start. So it could be that we would like to have a model that needs to have a warm-up period where the patients needs to wear a device with an algorithm for a couple of weeks to collect data from the patient to be able to predict the events that we would like to predict. Then it will actually be okay if the split is not on patient level, but the split is actually on case level. So then the same patient could be in both the training and test set. Then we need to choose which classifiers to use, and we should also look at the feature selection. So that's essentially the training part. So when we talk about interpretable machine learning, then it's much about the choice of model or algorithm or whatever you would call it. And you can say, for example, a neural network is probably not what we would call interpretable. It can be much more simple models like regression models. And why do we think that's a good idea? Well, in our experience, most HCPs would like to know what is behind a certain recommendation. There needs to be transparency. They would like to know, for example, if it was a dose guidance algorithm, why do the algorithm say that the insulin dose should be increased with 10 units? What's the reasoning behind that? So that is why we focus on explainable algorithms, and then it's also to avoid these simple human errors, I will call them. In Danish, it's called fejl 40, error 40, because the error is 40 centimeters away from the device or the screen, that is yourself. For example, there was this example with detection of retinopathy. Some researchers had a really good algorithm that could really classify the severe cases of retinopathy. But then when they tried it out in real world, it didn't work at all. And when they dived into the processing of the algorithm, they found that all the severe cases were handled by a senior consultant, and that person had a green coloring on the wall, and that color was actually picked up by the neural network as a feature that were very discriminative to these cases. So you can say it's a problem that you couldn't figure that out from looking at the model or looking at the features, and that's why we believe it's very important to focus on the features. Yeah, so no black box approaches, unless it is for implementation purposes, but that's another story. When it can be implemented in the end, then more sophisticated modeling could be the way. Then for the feature selection, we could. First of all, I can talk about the classifiers. We tend to use always more models at a time. So when we have set up our feature space and the complete programming setup, we try some different classifiers. That could be simple. In this case, it could be a logistic regression. If it was a numerical endpoint, it could be multiple linear regression. And then some more advanced modeling, support vector machines, random forest, k-nearest neighbor, and so forth, neural networks. But to have some classifiers, some different classifiers, and being able to benchmark the advanced classifiers to some more simple classifiers, where we, and also for validation, that we can easily see if we have done some mistakes in the advanced classifiers by looking at results in this more simple cases or the more simple models. Then for feature selection, if you have a logistic regression with the binary variable of hypoglycemia or not as your y on your y side, and then the x's, the covariates, will be your features, then And exhaustive feature search might not be possible. But still, again, we would like to test it in this way, not do a lot of advanced mathematical options like principal component analysis, because we would like to see the features in the end, and we would like to know the predictive power of each feature, at least in a combination with the other features. Then we could use forward selection, for example, just an example, and some cross validation to reduce variability if the data set is small. And this is just a drawing of cross validation. If you have 5 features, then you test 5 models in the first run with every feature by itself, and then you pick the feature with where the model performs the best. And in the next round, you then test that feature together with the rest of the feature in a 2-feature space. So feature 1 and 3 in one model, feature 2 and 3 in the next model, and so forth. And then it's maybe 5 that is best in the next round, and 2 in the third. And if you implement that in R and show some output, then it's easy to see what happens, and it's again also easy to validate if something has gone wrong. So, for example, here in round 1, rec 0 is the linear regression of the signal the evening before. That has been picked up as the most discriminative feature. It's the best feature. The outcome is the receiver operating characteristics area under the curve. So if you have a machine learning algorithm, and it's about separating, in this case it's a binary classifier, so it's about separating 2 classes from each other by the features, and this boundary can of course be changed by some weights, so that sensitivity would be 0, specificity would be 100, and the other way around. And then you can make this receiver operating characteristic curve. But just to say, a high value is better. And then you can see what happens then when in the round 2, where the next best feature is chosen together with linear regression. That's mean 0, and that was the minimal value the evening before of the interstitial glucose. So not a lot gained here with respect to AU ROC, but it's more easy to see the pattern. And here it's just presented as a curve. So the ROC AUC starts here at 0.69 with the first feature, and then adding another feature increases it by 0.04, and then it stabilizes, you can say. Nothing really happens here. Adding more features, and probably it will go down at some point. If we just kept on adding features, the performance will be bad. So we take the first maximum here. Then when we have done all these iterations and have found some features that we believe in, then the last point is, or the last thing is to test the algorithm, and we will, of course, or if we do it with the same outcome as for the training, then we will get a final ROC curve with a final ROC AUC. And if we are satisfied with that, that is not, if that is too low, well, then we have done some overfitting. Then we need to go back and see what happened. And then, of course, we can also look at the points and see if we then fix a sensitivity of 75, what is the specificity then? So in this case, it is not a superb algorithm, you might say, 75 and the sensitivity and specificity of 70%. But I see a lot of publications where there are sensitivities and specificities of close to 100%. And I really speculate if people have actually made some mistakes there. That is actually what we, or that is what we see when we try to then implement the algorithms on our own data. That is, it's definitely not results that can be that are generalizable. So yeah. I think that results in this area is actually something that is probably more realistic than these very wonderful results that are published a lot. Or maybe I'm just not good at setting up these algorithms. But then a use case could be that a patient wears this CGM sensor, continuous glucose monitoring device, an insulin pump, and an algorithm on a smartphone is continuously processing these data. And the patient can then maybe pull a prediction, pull a probability of a hypoglycemic episode during night, and then adjust the basal insulin rate or eat some complex carbohydrates, or yeah, set an alarm during the night. And it's actually something that is interesting for some. At least we have a large consortium together with Novo Nordisk and a lot of other companies where we are working on adherence to insulin for these patients with type 2 diabetes. And through cloud-based personalized treatment, a lot of buzzwords for getting the funding, but essentially it is measuring signals from the patients and translating that these signals into some meaningful suggestions to clinicians and patients. Yeah, and we also in this consortium we set up a quite huge trial, because then sometimes you figure out that you don't really have the data needed, especially if it's a new population where these devices are tried out. So in this case, we actually do a study to collect all these device data on 400 patients here in region North Denmark. And we of course take advantage of that when we have so many patients through, and also investigate the effect of telemonitoring. So we make quite a lot of these trials where we put a lot of devices on patients to capture these very valuable data. But then we also try to make some evidence regarding a telemonitoring setup or a new way of training the patients. Yeah, so telemonitoring with decision support, that's the end product. And nocturnal hyper alert is here part of the complete product. I will not say anything about this. I think I'll go to the take-home messages, and then I will also turn on my light because it's morning at your place, as far as I know, but evening here. First of all, I would like to say that a lot of sources to big data exist, registry data, data from already big collected clinical trials. But of course, one could also run own trials to collect all the data. And then of course, think problem-based. Is machine learning, is AI really the right method for answering the questions or testing your hypothesis? There's a lot of other fine things. And actually, in my opinion, what we are really lacking in digital health is visualization of data. So much more data integration. So a lot of our clinicians request a combined view of data from the patients. That is really non-existing actually. They have to go into a lot of different systems, and it's easy to find the information that they need. But the add-on to that would of course be processing of the data, which could be with machine learning. If you then use machine learning, then feature extraction is key to obtain a good result. And we would say that explainability is needed if you would like to convince HCPs to use the smart models. So that was what I would like to say.
Morten, thank you very much. This is very enjoyable, listening to a complex problem with such an ease. Thank you to make it very clear for us. Now I open the floor for some questioning. Either you can put in a chat or speak